Hello, thank you very much for joining me. You join me this week as I get ready for a live stream human dissection class, which is what I do, in case you hadn't realized. And I'm in North Carolina. I've got my stuff ready. I brought it all over from the UK and got the cameras set up, and it's quite it's taken me 2 days to get everything sorted, cables everywhere and goodness knows what else. And so it's quite a big old thing that I have to do as I sort of drag myself around the world. But anyway, welcome, and there's still no reason why we can't wear a nice shirt wherever we happen to be. This week I am talking about the greater omentum, and it's one of those things that doesn't really get talked about very much. It's not particularly well known, but it is a really wonderful structure and really interesting, and I hope you're going to enjoy some of the stuff that I'm going to show you this week, some pictures about it. And so without further ado, let's crack on for this week's Not a Collection of Parts, the greater omentum. So just before we get started, I want to put this series out as free for everybody as much as possible, and in order to do that, of course, it does take me more time than it should do, really. So if you do appreciate the work and you want to keep it free and you want to pass it on to people, then if you could support me on Patreon, I would be most grateful. A little bit goes a long way, and it helps to keep this kind of stuff accessible for as many people as possible. So thank you so much. So the omentum is what you can think of as an internal janitor, a caretaker. And I don't know about you, but when I was at school, you had that caretaker, and he walked around. He didn't have a nice flash bucket like this, but he walked around the halls, and he was always there. Sometimes with a bit of an imposing and scary presence. But the enduring memories I have of our school caretaker was the smell of sort of pine disinfectant and sawdust. And later on, I got a job when I was in my teenage years in my school, and you used to push the sawdust up and down the halls, and it had that sort of certain smell, and that smell, I can almost bring it to life now. It's a very distinctive smell. So what is the greater omentum? So the greater omentum is, it was once thought of as a sort of an insulator of the body, and a storehouse, and where it is and what it's doing we'll get to shortly, so don't worry about that. But it was thought of just a sort of fatty apron, responsible for keeping us warm. And going back to Galen's time in 2nd century, he was convinced that it was the thing that was keeping the guts warm, and the reason he thought that was because a gladiator was brought to him that had been injured in a battle, a gladiatorial battle, and he'd had a omental resection, so it had been sort of taken away, and he was forever cold after that. So that was Galen's idea, that it was a thing to keep us warm, an insulator. And it really hasn't changed much over the years. There's a lot of material studies that have talked about removing it as part of fat loss surgery, and they stopped taking it apart from bariatric surgery, not because anybody thought better of the omentum, but simply because there wasn't the evidence to say that it was doing anything, that it worked. But it is a wandering policeman. We'll get into, as I said, what it is and how it works and what it looks like very, very shortly. But generally speaking, we can understand that there's a huge thing that it does. And these days, even though we don't fully understand it, we sort of now do understand it as being a major organ of the immune system, and having significant role in the defense against pathogens and injury. And so, not just it's a front line of defense against infection, injury, disease, cancer cells, you name it. So we'll have a little look at what it looks like, or what it's supposed to look like. So we go to the books and you look up the omentum, then this is what you're going to see. And as you may imagine, I'm going to change that little view for you if we possibly can. So what it's supposed to look like is this, and we can see here that. So here we are. Here's our liver. Here's the curvature of the stomach, and we have this thing up here which is the lesser omentum. This is the lesser omentum. This sort of sits around above the stomach, and it spreads across around the top above the duodenum, around the back of this portal triad here. And then this is the greater omentum as it comes off the curvature of the stomach, and it sort of folds down and around and back. Another picture from Gray's Anatomy. Always like to refer to the artist who was Henry Van Dyke. He did all the pictures for Gray's Anatomy. People don't tend to know who he is. But here we go. Here's the omentum here again, and it's sort of, you can see the blood vessels in here, the blue and the red blood vessels. Of course, that's what it looks like. If we go to our muscle program, go to our anatomy program, then here we have, this is what it's supposed to look like here. And on the left, what you can see is the right, left and right are the same. The right is highlighted, and it looks almost translucent here. It looks like it's sort of you can see through it, and you can see that it's supposed to cover all the way down from the stomach down to the pelvis, and all the way down into that sort of pelvic bowl, that pelvic cavity. And in theory it does, but it doesn't necessarily follow that in practice that's what's going to happen. And then a great dissection picture. Again, it's showing you, there's a little clue here as to where we're going with it, because the greater omentum here is looking pretty thin. It's looking, if you go back to the this one, it sort of looks translucent. It doesn't look quite the whole complete unit that we're going to see it as, but it does look a little bit more like the previous one, the translucency. Now, because it does a few things, because it has a few jobs, what we're going to have to do is to discuss some terms of reference for the things that we're looking at. And the first one that we're going to be looking at is just to understand what it is that we're dealing with, stuff that we need to know. Going to keep it simple, but we're just going to talk about a couple of things. And the first one we're going to look at is macrophages and phagocytosis. And this is an important phrase, an important term, because macrophages are found everywhere. They're found in every single tissue that we have in our body. They're a type of white blood cell, and they play a massively important role in the immune system. And with the role of clues in the name of phagocytosing. So phagocytosing means the engulfing, the swallowing of antigens, the pathogens and antigens that invade us, such as bacteria, cancer cells, and dead tissues as well. So anything that's there as a result of injury or damage, then the macrophages come along and sort of swallow it up. And I'll show you a little video of that in a second. And they destroy this, and the process of this destruction is called phagocytosis or phagocytosis. And they're able to present some of these pathogens to other T cells in order for them to be able to, if they don't recognize them, to form a recognition, and so therefore to become part of recognizing, so they're part of the innate immune system. So they do a great job. The interesting name is they come from a Greek phrase meaning big eaters. So where was it? The Greek is makros, large, and phagein. Again, I'm so sorry to my Greek friends if I'm getting it wrong. That means to eat, and so they eat up cancer cells and things like that, things that have been killed or damaged. And as I said, the process is known as phagocytosis or phagocytosis. And so this is what one looks like, a little splot, as it sort of sits there and splots around and it's sort of dealing with this, helping to clean this system up, like this image of traveling. I'm going to show you a couple of little videos. This is a macrophage extending its arms outwards. It's sort of the arms are called Philadelphia, which is a great phrase. And they two arms out, and they're extending to engulf two particles. Possibly pathogens. We don't really know what they are. These are stained blue, so in a mouse. So it's a picture of the macrophage. Kind of cool little video here. Let's have a little look at this.
This high-speed video shows a macrophage chasing down planktonic bacteria. This is likely a segmented filamentous bacterium, as it appears to be attempting to escape capture. Eventually, the macrophage is able to phagocytize the bacterium.
Let's look at that again. I think it's worth looking at it again. Just so we can take it on board. It's a lot of these videos that you see, a lot of these animations are kind of illustrations, if you like. They're not, they shouldn't be taken literally, but they're sort of cartoonish. It's things are certainly things. The second part of it is generally what you're going to see in under a microscope. But a lot of these times it's sort of speeded up and simplified. But I think it's kind of cool to watch. So let's have another quick look at it.
This high-speed video shows a macrophage chasing down planktonic bacteria. This is likely a segmented filamentous bacterium, as it appears to be attempting to escape capture. Eventually, the macrophage is able to phagocytize the bacteria.
So the phagocytose, and the macrophage is able to phagocytose, so eat it up, destroy it, get rid of it, and that's what we're dealing with. Another one here, this is an extended part of the immunology study that I've been doing at university, and it's a little long and involved, but I'm going to show you the first little bit to show you that the process of migration of these immune system cells and how they travel around to look for things, and that's going to be important when we come to look at what the Omentum's doing.
In the presence of infection, chemotactic molecules are released from the complement system, mast cells and leukocytes. These, in turn, stimulate macrophages to bind to endothelial surfaces in blood vessels near the site of infection, facilitating their passage through the endothelial wall. Once the macrophage is within the tissue fluid, it migrates towards the site of infection across the surface of the extracellular matrix. This migratory process is termed chemotaxis. Its direction is controlled by the concentration gradient of free chemotactic molecules, such as C5a.
I'm going to stop that there because I'm going to kill myself. It's quite long. But essentially the idea is that it migrates and it receives the signals of what it needs to do, and then it travels around in order to be able to do that. And that's the great thing about it, is that it can pick up on what it needs to do, and you know, it can do the job it needs to do very, very easily. Right, the next bit we're going to talk about, which is a sort of reference again, so we understand what we're dealing with, is something that we call the parietal peritoneum. All right, so let's put that on. The parietal peritoneum. So this is a really thin, fine lining that sits sort of around most of the organs, the sort of the internal organs of the body. Now, there's different types of peritoneum. You've got pleural peritoneum up in the thorax, but this is parietal peritoneum. It's in the abdomen, and it sort of winds in and out of the abdomen. I'll show you this image here. You can sort of see it here. This is the lining of the peritoneal lining as it's sort of going backwards and in and out. So some of the tissues that you'll see are outside of the peritoneum. It's all green in here. And can you see here this lining here, this big green bit? And the peritoneum is the part of the omentum. So the omentum is a peritoneal fold, effectively. The main thing about this is that it's called a serosal tissue. So it's a serous, not serious, a serous membrane. That means that it creates its own lubrication. So again, that's an important aspect in terms of its ability to be able to move around and migrate according to, you know, where it's needed. And it's a sort of a partition between the organs and the abdominal cavity. So the peritoneum can get inflamed, it can get infected. You'd have peritonitis, and very serious, and you know, can shut down the organs and result in death because of that inflammation. And so something like the greater omentum, you know, you don't want to get rid of it because you know, you need to be able to make sure that it's going to be able to do its job. So when we look at the dissection, the parietal peritoneum, I'll show you there we go, a little picture of it. There's a parietal peritoneum. So this is the wall of the transversalis fascia, if you like. So the muscle of transversalis fascia is here, and that's what we're looking at there, is the transversus abdominis muscle, and then the transversalis fascia here, and then this filmy bit here is the parietal peritoneum. Yeah, and that's that little fine tissue that we've got. And again, if I just move it on a little bit, you can see this is separated out from transversalis fascia. And it's not often that you see this being separated. It tends to need to be a little bit dry, like sort of paper. But look at how tiny that is. But you can sort of see that this idea of that there would be lubrication taking place around this tissue creates its own lubrication. And there's quite a nice little video of this, and I'll just sort of show you and you get the idea of how wet this is the fluidity of it, but also like, you know, like very fine ice that's formed. And unlike lots of different types of connective tissue, then this is fairly sort of static in terms of its position. There's sort of one layer of it. It doesn't have lots of interdigitating layers. I mean, it does, you know, you can sort of see there is a bit there. And then you see these little dewdrops of fluid that hang around on the line. But even here, you know, like I say there's no differentiating layers, but you can see there's different directions, and so there is structure and integrity to it as it moves around. And it kind of looks like, you know, like frosting on glass, really, like a frozen glass. Yeah. So that's the parietal peritoneum, pretty important bit. So we're understanding a lot more about the idea of gut health and how important it is for us to maintain equilibrium and a status within our gut cavity. And we're understanding a lot more about how mood and depression and mental illness and behavior almost is associated with what's going on in our microbiome in our gut. And when we don't know, but perhaps we're looking at the omentum as being part of that. So we're going to see we've seen what it should look like here. So now it's a case of you know, what does it really look like as far as our revelations are concerned? What are we going to see when we look back? So an interesting thing about the omentum that I found out, that, you know, I kind of didn't really know this, but it comes from the Egyptians, and the Egyptians when embalming, the Egyptians did their own embalming a lot. They used to assess omens by looking at variations by what we see as the omentum. So they'd look at the omentum and they'd see variations because it's a very variable tissue, and from there they would gather omens. So it was an ominous tissue that was the omentum, and that's where that phrase comes from. So the omentum moves around, as I said, and finds different sites of inflammation and infection. I'm going to show you a little video where that's happened. And so let's have a little look at what some of the my dissection pictures are. And as I said, before we get there, I always want to make a little note of thanks and a thought to the donors and our families, because, you know, without that we wouldn't be able to do the work that we do. So it's a wonderful thing, and thank you to all donors and the families the world over, wherever that may be. So I've been fascinated with the omentum for quite some time, simply because its mobility and how it moves around. And so I started to ask my students, when they were opening the abdominal cavity in dissection, to not do it unless I was there to take a picture. So we wanted to take a picture and measurement. I don't quite know what I'm going to do with all these images I've got, but, you know, why not? So this is what we're looking at here. We're looking at the inside of the abdominal cavity here. So we've opened up the abdominal cavity, we've made an incision through here, and then what you've got here is let's put this on a bigger screen, you've got an adhesion. You've got the omentum sticking itself to the inside of the abdominal wall. As to the reason why, I don't know, but it shouldn't, because we've already seen that there should be slippery sliding movement around between the omentum and this wall. So any adhesion going on here means it's stuck somehow, and we shouldn't be seeing that. It should just lift up and open it, and we should see that nice and clearly through it. But here we can see that it's stuck, and it's all the way down into the other end. On the other hand, this is a nice big. Now, I can't say the person was healthy, because obviously they were dead. But this is the white, the sort of the yellow covering that we will see, that is the classic greater omentum. So look at this. There it is. It's spread all the way from the bottom edge of the stomach, tucked all the way along. And what it does is it sort of folds back on itself. So what happens is with the omentum is that if you imagine there's the stomach, and it sort of falls down from the stomach, and it folds back underneath itself, and then comes back to attach to the transverse colon. And so, like I said, it's 4 sheets of peritoneal tissue, and that's really what the parietal peritoneum is. But you can see the difference here between the previous one, the difference in colour, and the amount of fat that's stored on it. We go back to that. The amount of fat that's stored in this, compared to this one, is just remarkable. This is what's happened. So we've now folded this back. And so from here, this tissue has now been folded back to look at sort of the the back of it and the inside of it, if that makes sense. And we can see the small intestine lying around on underneath it, and we can see the sort of the way that this tissue is then attached along sort of what would be along here, the underside of the transverse colon. So it's been flipped back in here. Another view here, a slightly different view, slightly different, again, just to give you some variation of it, and how the fact of this here is not stuck. It's a slightly different cut, but again, just lay the ruler down so we get an idea of the distance and how big it is, and we can sort of see a little bit of descending colon there. Sometimes the viscera is not in the place that it's supposed to be. We always go, well, this is transverse colon, ascending colon, descending colon, ileum, jejunum, all that kind of stuff, and it's not quite often. I mean, really often, then you go, well, that's not where it should be, or the kidney's in the wrong place, or the ileocecal valve's not there, and so you just don't know until you get in there where it is, because palpating it, it feels just like a big bag of wet goo, which is what it is when we're alive. There we go again, and this is again. So this is really interesting. This is a different donor, different sample. But what you're looking at here is the abdominal cavity having been opened, and the omentum just doesn't appear to be there. Where has it gone? It's moved somewhere. It's moved up around the liver, or it's moved up. I think in this instance, it moved up into around the back of the spleen, and this is not uncommon to find that the omentum just isn't there. It's just not gone. Now, we mentioned it being removed and taken apart, an omental resection. And of course, this can happen, but it's very rare, and I've never seen one completely removed. But I have seen quite a lot like this, where it doesn't appear to be there, and then you have to go and look for it. And we'll look at what that looks like in a minute. I think that's the same as the previous one. So this is the what you're looking at here is you're looking at the stomach, and this is the underside of the stomach. And this is the omentum coming down off it. And again, it's worth a note here about how much of this connective tissue is attached to it here. So following a blood supply. This is the stomach into here. Again, another omentum. Yeah, it's kind of like holiday slides, isn't it? Yeah. This is us at Blackpool. This is another one of us at Blackpool. This is another one of us at Blackpool from a different place. But no, this is a lovely omentum, but it's a different shape. We've got some darkness in there. What does that mean? Hard to say. It could have been some infection. We just don't know. Because we don't have really a comparison. We don't really know what a normal omentum in life would look like. And so when we open them up, all we can see is the variation. And without some reasonably detailed medical history, we don't really have any idea what we're looking at, to be honest with you. And then this is that other one that we saw again folded back. Now there was some carbonation in the lungs. You can sort of see this in here, and there's a bit of carbonated lungs. So there's a possibility of there being some cancer in here. But again, without the pathology in front of us and results, it's just guesswork as much as anything else. Just a very quick little look at a little video here that shows you how we sort of get into it, and so I'm going to show you this, and we'll pop back and finish off in a second. So there we go. There's a little tissue here that I'm very, very fond of, and he's not in the right place here, but it is this. Oh, wow. Okay, see this baby here? So this fella here is called the greater omentum. Yeah, isn't that beautiful? And this is the greater omentum. It's a very, very lovely bit of tissue. It's very special, and it was, when we came into it, it was sort of, this was sitting on top of it. So this looks to me, we're getting a little bit more of a handle on what's going on here. This looks to me, it can't be transverse colon because the parietal peritoneum is not attached to it. So, or is it? No, that's interesting. No, it's not. And his parietal peritoneum looks in quite good nick. So the parietal peritoneum is a tissue that comes from the stomach, from the greater. Thank you. Yeah, it is. It's like an apron. It comes off the greater curvature of the stomach, the greater fold of the stomach, and it comes down and it folds back around. And I don't know if I can quite show you this, but. I don't even know where we are in here just yet because I haven't opened everything up. But so this is. Huh?
When you lifted that up, I thought I saw it.
Yeah. So this is his stomach here. This is the stomach up in here. So this is his transverse colon. All right. So that's what this is. This is transverse colon. This is stomach up here. You see that up in there? All right, it's got some fluid in it. So the omentum is coming down off the stomach, and it's folding back down, and it's curving itself back around, and it's coming up and attaching itself to the transverse colon here, and it's an apron. And I'll see if I can show it to you. Say again.
Is it tough?
Is it?
Does that have a lot of integrity?
Yeah, normally, I mean, in a lot of circumstances, what you'll see is that it's full of fat. You can get one that's really, really thick and full of fat.
And like a shock absorption.
Okay.
Well, no, I think it's way more than that. It is a floating organism, and it moves around the abdominal cavity, and it soaks up toxins. So it's a major lymph organ. It's a major lymph organ.
That's interesting.
Yeah. So and what it does is that it comes down and it folds back. You can't quite see it, but quite normally, you can get the idea. See that there?
Yeah.
So that's what I'm talking about. So you see how it folds, and then that's like trying to pull a rubbish bag or a trash bag apart. It sort of folds, and that's your folds, as it were. Okay, slightly sheet it back. Okay, there we go. So it sort of folds back. So it's a double-walled tissue, double-walled structure. And it soaks up toxins, and quite often what you do is you find it tucked right up around the spleen, you know, in cancer patients or people that are sick or what have you.
And what is that called again?
This is called the greater omentum, yeah? So we have a greater omentum and we have a lesser omentum, and the lesser omentum has a bursa, and we'll talk about that another time, and there's a little space in there which is called the lesser omental bursa, and that's the site that has the hepatic portal vein, which is the hepatic artery, the hepatic portal vein, and the common bile duct, and that is the portal triad.
30-minute warning.
Thank you so much. So that's so thank you. So that is our greater omentum, and isn't that beautiful? What do you think? Isn't that lovely? It looks in this guy. He looks. Let's get a little bit of light on him, and he is like a little piece of lace. Yeah, it's hard to imagine that he is. Yeah, isn't that beautiful?
It's like a lace
And every
Yeah.
time we go into one of these, you find it in a different place.
Yeah.
It's never in the same place twice. And
Over
so
here,
those
it's
of
like a
you who've been to
lace
visceral manipulation, where they talk about the general place where all these things are, here's an experienced
Can you press that
anatomist who
button
doesn't
right on the
know
top there?
what he's
Just
looking
press that
at
one.
even when he gets in there.
Just button there, right there.
You need to deal with generalities, not specifics
Okay,
when you're
I'll
doing
just
this,
see if we can
because
zoom in a
every
bit.
single
See-
body
so
is
come in.
truly different in the way that these
Okay,
pieces are put
and
together.
again, taking another picture. That's a picture, still picture. Yeah, isn't that beautiful?
Shine the light on the other side.
Shine.
Can we do this? Shine
Yeah.
the
Come round. So it's a. As you can see, it's a very lovely and very delicate tissue, and I'm just going to take the sound of that, but yeah, we're just getting some light behind it, and you can see here it's virtually translucent. You know, it's almost you can see right the way through it. That's it. Yeah, and so therefore that's just areas where fat hasn't stored, it's been used up, and you can see the blood supply again, so that it's going to be taking a lot of those toxins away and up to the liver, and see that lace-like element to it. I've got one more quick little video to show you in terms of what that looks like when we sort of get underneath it and when we have an adhesion here. So let's have a quick look at this. Just above the pubis. And then as we lift put it up a little bit further. So now we can see this. Sorry guys, can I just ask you to so what we're looking at there is we're looking at how the omentum has become adhered, it's stuck to the underside. So the inside of the abdomen, probably through scarring, and we're looking inside on the all the way down through the transverse abdominis, and it's absolutely stuck fast onto there. There's no way you're going to pull that off, and the small intestine has adhered to it as well. And so the omentum is stuck onto it. The omentum in turn is stuck down through the small intestine, and any movement that you're likely to get is going to be massively limited and restricted as far as the rest of the tissue is concerned. So yeah, that's a sort of peak inside underneath the lining. What you're looking at just into this bit into here, where I've got the forceps here, is you've got the omentum, you've got the wall of the abdomen there, and then you've got this really strong adhesion. That's it. And that's the omentum there that I'm poking around with. And this adhesion is going all the way down, pinning down the small intestine. Why? I'm not really sure. We don't know. It could have been a surgical intervention. It could have been, lots and lots of reasons. Yeah, so this is what we have. And to be honest with you, like I said, we don't really know. There's lots of questions that we have about what is it, what else does it do, what else does it contribute to, when people have had it taken away, what other effects do they have? And so it's one of those things that we're not sure. But it is a beautiful organ. It's there all the time. It's moving around. It's going to be part of us as far as our infection is concerned, and it's going to be responsive possibly to stress as well. It's one of those things that our gut feeling, if something can move around inside of our gut tissues, how else is it going to contribute to the rest of our gut health? And we know that our gut health is part of our general sense of feeling, so it's in there. What's it related to? I don't know, but it's part of our immune system, lymphatic system, and it's fed by our blood supply, so it's more than just a single organism. There we go. Thank you very much indeed. Please do consider supporting me on Patreon. I would be most grateful for your support, and you can get a few extras if you become a supporter, and get a Q&A with me every month after one of these sessions, and I'll put specific stuff up there for Patreon supporters. So please, it's a great way of keeping this affordable or free for everybody. And next week I will do something different. So thank you very much again for joining me from wherever you happen to be in the world, and I will see you again on Not a Collection of Parts. Thanks very much. Bye for now.